Bismillahirrahmanirrahim. General Afshin Iqbal, Halal Imtiaz Military, General Wasim, and dear fellows, Assalamu alaikum. I am Dr. Imran, one of the cardiac surgeons at AFIC. I have a small experience of minimal invasive cardiac surgery. I thought it's worth to share it with you and get some better advice. And we start with some statistics. About 310 million major surgeries are done per year in the world, and over 1 million are heart surgeries. Less than 5% of heart surgeries are minimal invasive, and even lesser are performed here in Pakistan. Minimal invasive heart surgery is termed for procedures performed through one or more small chest incisions. In contrast, open heart surgeries use one long incision down the center of chest. The minimal invasive approach may offer less scarring and pain and faster recovery. These are small incisions as compared to, how can I use the pointer? These are the conventional incisions, and these are small incisions which we make in minimal invasive cardiac surgery. Minimal invasive cardiac surgery is done through two incisions, partial sternotomy and sternotomy-free mini thoracotomies. Most of the aortic surgeries are done through partial sternotomy, and through rest of the procedures are done through thoracotomy. Cardiac surgery is the last surgical specialty which adopted minimal invasive approach. The rest of the surgeries adopted it in 80s, but cardiac surgery adopted it in late 90s. This is because of two major factors. Number one, access. Access is the problem in cardiac surgery. And second is cardiopulmonary bypass, which we established, and no other specialty uses cardiopulmonary bypass. The problems which we face during minimal invasive cardiac surgery are rigidity of the chest wall, the movement of heart. Rest all the organs are still and we operate on them endoscopically or minimal invasive way. But the heart is the moving organ, so it's difficult to stitch the heart. It's full of blood, and there are chances of hemodynamic instability during procedure. Why we are doing or adopting minimal invasive surgery is because it has small incisions or scars. It causes less pain, early mobilization, early return to work, less traumatic, low infection rate, less bleeding, shorter stay at hospital, and safe reoperations. But the most important thing is patient demand. Nobody wants big incisions anymore. To carry out minimal invasive cardiac surgery, normal cardiac theaters are insufficient. We need to build better operation theaters and hybrid operation theaters like this. Let's go with the surgical procedures. The benefits of minimal invasive heart surgeries are minimum opening of chest and cutting of bones, faster recovery, less pain, low risk of complications, decreased blood loss, less scarring and hospital stay. But there are certain limitations. Not every patient is ideal for minimal invasive surgery. If we have diffuse coronary artery disease, presence of calcification on mitral valve, ventricular functions are impaired, if there are pulmonary adhesions and you cannot pass through them, abscess formation or endocarditis, porcelain aorta, and so on. The most important thing is in this we use single lung anesthesia, and T transesophageal echo is mandatory. We go for SVC cannulation by anesthetist, and we use external defibrillating pads. The positioning of patient is also important, and we mark them before surgery. There are different level of incisions. With experience and with more technology, you proceed towards the higher level of incision making and smaller incisions. Here we use superior vena cava cannulation and inferior vena cava cannulation rather than right atrial cannulation, which we use in conventional surgery. Here is our assistant, and he is doing femoral cannulation. We make mini thoracotomy incision like this, and this is one of our patients. The incision is of about 3 inches, and this is mitral valve replacement. This is bicuspid aortic valve through mini sternotomy, again 3 inches incision. This is one of our mentor. His name is Fayaz Hashmi. He came all the way from USA, and he is performing minimal invasive CABG, and this is op cab without cardiopulmonary bypass. Here I want to share some studies. Here is first study. It is meta-analysis which was done on 9 individual intervention groups in 2060s, and it concluded that minimal invasive cardiac surgery is as safe as conventional surgery and could reduce cost due to shorter period spent in ICU. Here is another study which was done in 2017 in Germany, and it says specialized surgeons and centers can now carry out many cardiac valvular and bypass operations via mini thoracotomy rather than sternotomy. According to current evidence, these minimal invasive techniques yield results that are at least as good as classical operations. Another study with 1,000 patients shows that in first year and at 3 years, the mortality in minimal invasive cardiac surgery was lesser. These are the procedures which we can do with minimal invasive surgery. Upper 4 procedures, mitral valve, aortic valve, tricuspid valve, and atrial septal defects, we are doing regularly at AFIC. We are getting training on coronary artery bypass graft surgery through our mentor, Dr. Fayaz Hashmi, and we have yet to do ventricular assist device and MACE procedure. We started in 2013, and till 2022, we have done some cases, more than 100 cases, and here is the result. Once we compare these results with conventional surgery, we have found out that the cardiopulmonary bypass time was more and cross-clamp time was more. The age in these patients was more. These were the significant factors. Rest of the things were almost non-significant. Another thing which we noted, the death was about 1.86% in conventional surgery and 0.9% in minimal invasive surgery. We lost 1 patient in minimal invasive surgery. Reopenings were lesser in minimal invasive group. We did not हम कमांडो बिल्कुल नहीं बने इस सर्जरीज़ के दौरान। हमने वो पेशेंट चूज़ किए जो बिल्कुल नॉर्मल कर्व के नीचे थे। हमने कोशिश की कि सारे पेशेंट्स ऐसे हों जो नॉर्मल हों और बिल्कुल एक्सट्रीम्स पे ना हों। एज ग्रुप हमने बिल्कुल नॉर्मल यूज़ किया। इसी तरह आप वेट देख लें, हमने एक्सट्रीम्स पे नहीं गए। हाइट, सेम BMI, हम बिल्कुल नॉर्मल पेशेंट्स में गए। EF हमने अच्छी EF वाले पेशेंट चूज़ किए। दैट्स वाई प्रोबेबली आर मोर्टेलिटी वाज लेस। ज़्यादातर मोस्ट ऑफ द valves were used were carbomydex and St. Jude mechanical valves, and we remained in good valve sizes. हमने बहुत छोटे और बहुत बड़े साइजेस यूज़ नहीं किए इन सर्जरीज में। Almost most of the patients were mitral valve replacement and then aortic valve and ASD procedures. Inotropes, again same results. Key message with this is that with relevant specialization it is possible to undertake many heart operations as minimal invasive procedure. This can be done not only through partial sternotomy but also completely without sternotomy through right and left mini thoracotomy. That is called sternotomy free. There is no evidence to date that allows concrete conclusion about the superiority or inferiority of such sternotomy free techniques. Registry studies imply that minimal invasive procedures can also yield good results. Randomized trials सर अभी तक इस पे कोई नहीं हुए। नेशन वाइड जर्मनी में उन्होंने देखा था कि जी हाफ ऑफ द माइट्रल प्रोसीजर्स एंड तकरीबन क्वार्टर aortic procedures are done minimal invasively. Our recommendations in a survey, it was recommended that the future cardiac surgery, 83% of respondents agree that residents training in cardiac surgery should be modified to add at least 1 extra year of training in catheterization, laboratory procedures including coronary artery, valvular, aortic, and arrhythmias, thus introducing interventional surgeons. Here is our mentor, and I want to mention this gentleman, Dr. Rehan. He is the biggest support for us. Initially, once we used to do the mitral valve or aortic valve replacement, we used to have many surprises on the operation table. The ultrasonic findings were different as compared to what we used to find on operation table. But this gentleman, he helped us a lot. He, in fact, trained well in transesophageal and transthoracic echo, and we have relied on him, and this has improved our result tremendously. And many thanks to him and his presence. And now we are training future surgeons, and let's hope for the best. This is our team. Thank you very much, ladies.